Like the rest of our bodies, our eyes change with age. Glaucoma, cataracts, diabetic eye disease, and macular degeneration are just the beginning of a long list. The Aging Eye tonight on call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. If you think about it, the whole idea of being able to see the world around us is pretty amazing. As we age, there are changes that may take place that affect the quality of our vision, however. First, let's take a look at this week's Prairie Doc quiz question. If left untreated, the most common cause of blindness in the elderly around the world is caused by A, glaucoma, B, macular degeneration, or C, cataracts. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. And you only have 10 minutes to get that quiz question in. But we're going to answer your questions throughout the evening about vision and your eyes as they're called in or sent to us via Facebook or email. Call in your questions, please, to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are Dr. Vance Thompson of Vance Thompson Vision in Sioux Falls and Dr. Michael Eide with Ophthalmology LTD in Sioux Falls. Both of you, thank you so much for joining us tonight. And we're going to have a ton of questions. I can feel it. Get your questions in early. But we love this topic because generally a lot of people like to watch this particular show. Or if they can see it, that's the problem. So, Mike, tell us a little bit about you. You're from where?
I went to high school in Newell, South Dakota,
Newell.
20 miles north of Sturgis. So I'm a
West
River guy.
West River guy. And you've been, you did your training at?
So I went to medical school at USD, and then I did my ophthalmology training in Chicago.
Okay. And then you've been here practicing?
9 years now.
9 years, yeah. Just the blink of the eye.
I know, it just flies by.
Yeah. And Vance, you're working with two other partners and a group of other partners, really.
Right.
At Vance Thompson Vision. Tell us about how that started.
Well, I practice with Dr. John Birdall, Dr. Allison Tendler in Sioux Falls, and grew up out on the plains. I graduated from Gregory, went to USD also. I got a degree in chemistry, went to med school there, and did my ophthalmology training at the University of Missouri at Columbia, and then did a fellowship in refractive and cataract surgery in Kansas City, then came back.
And you were one of the original LASIK providers, which is interesting to me.
Got involved in the research and development of LASIK when it was in the FDA monitored stage, and it changed my career. It's been amazing to grow up with it.
You know, one of the things that we talked about the eye diseases, and we had the quiz question. We don't want to give away the answer for the first 10 minutes. But let's talk about cataracts. We have a picture of a cataract that we're going to talk about, and we can, Mike, explain that.
Sure.
Go back. We want back one. That one, yes. What's the difference?
So this is a dilated eye, so you can tell the pupil is quite a bit bigger than it would be in a person who hasn't had eye drops in. But if you look in that area that I've circled, it's not black. It's not like we would expect it to look when we look at someone's pupil. So if I get rid of that, you can see that a little better. It's the lens of the eye, and the lens sits just behind the pupil. And this one has developed a cataract, and cataract just means that the lens isn't clear anymore. We all have a lens in our eye, and at some point it's going to do this. I tell people we get gray hairs, we get wrinkles, and we get cataracts.
They say it happens with solar exposure, though? Is it with people who don't wear sunglasses? I mean, is that really true?
It's thought to be accelerated by some things. You know, solar exposure maybe. They've looked at
Smoking?
smoking, also diabetes and some of the diseases that cause chemical imbalances in the eye. If you're injured, you know, if you just get hit in the eye real hard as a kid, you can develop a cataract as a child even. Some kids are born with them, congenital cataracts.
Right.
So we don't fully understand what causes that reaction.
I had a vitrectomy because my vitreous was giving me trouble, and then I had cataracts.
Yeah.
That's part of it too as well.
We see that very commonly. You're almost guaranteed to get a cataract after a vitrectomy surgery.
Okay. We have a video of cataract surgery, Vance. I think it's you who were doing the surgery. So we'd like to see that roll in here, and then I'd have you, Vance, kind of explain what's going on through the roll in.
Sure. In cataract surgery, we're basically replacing that lens, and there's really no reason to have cataract surgery unless you're frustrated with your vision. You know, good pair of glasses, sometimes you just need to get your glasses changed to go ahead and have cataract surgery.
The opening of that capsule. In cataract surgery, we make 2 incisions. They're both very small, actually, so that we can do them without a suture. And we inject a thicker substance. We call it a viscoelastic, but it helps inflate the interior of the eye. It helps protect the interior of the eye, because the cataract sits right behind the pupil. Right now the pupil is dilated. We're going to make an opening in that capsule to get to the cataract. That same capsule is going to be what holds the implant. Then we use a little fluid to what we call hydrodissect, or separate the cataract from the capsule. Then we use a process called phacoemulsification. Phaco is a Latin term for lens, since we're working on the lens. Emulsify is to break it up into small pieces so we can take it out through a small incision, because the cataract's big. Rinse. So now that we got the cataract out, we work on vacuuming the capsule. We want it crystal clear to hold the implant. So this is called the cortex that we're removing, and the epinucleus. That capsule is as thin as saran wrap. But it's a very important capsule because it's what held your natural lens, and it's what's going to hold the new one. So we inflate it. We also are going to measure the power of the eye. This helps to choose the implant that's perfect for the rest of his life. The implant's been folded almost like a little burrito or a little taco. It's made out of acrylic, a crystal clear material that will give great vision for the rest of a person's life. Even if we're taking the cataract out of a child, acrylic will be stable and clear for the rest of their life. Just a wonderful material. Now we're removing the viscoelastic material, the thicker stuff that kind of inflated at the beginning, making sure the implant position is perfect. And then we're going to inject the antibiotic. Some big studies that have shown injecting the antibiotic at the time of cataract surgery reduces the risk of infection.
That's it. That's fascinating to see that surgery. Thank you so much for allowing us to be in there and to see that last week.
Yes.
Yeah, any comments about that particular procedure that you had?
Cataract surgery is the most powerful way to correct vision there is. The lens of the eye provides 1/3 of the focus power. And so oftentimes we're putting in a 20 power lens, and if it was 20 power glasses, that would be extremely thick. And that's why that implant is so important, because in the old days, people had to wear those really thick glasses.
Boy, I was still practicing when they had these big pop bottle
and the implant, it revolutionized it. And this, the most common surgery performed in medicine today has an extremely high success rate. But again, there's no reason to have it done unless you're frustrated with your vision.
Right. Any comment about the vision loss that goes with it? I mean, how long do you go before you decide?
We hear the question a lot of, is my cataract ripe? I think
Yeah.
that was
Right,
common terminology
right.
15, 20 years ago, and it's really hung on. And the answer is there's not really a ripe anymore, and as doctors we used to say, today's the day you qualify.
Right.
And now it's more of a gray line, I think,
Right.
where
I do
it's
too.
like Vance was saying, if you're happy with your vision, leave it alone. And I have patients who have 20, 40 vision from cataracts, and they're happy. They can read the newspaper, they passed their driver's test last week, no complaints, and we leave those be. Whereas, and then I have some patients who maybe have a little different vision demands,
Right.
and they walk in and they're 20, 30, they're a little bit better vision than that other patient, and they say, this is miserable, I can't do this anymore.
Can't see.
Yeah.
That's why when you hear someone worried that they have a cataract, I always tell them, like Mike said, everybody gets them. And really about a third of them come out. You know, most cataracts people live with their whole life. It's just removed if it's frustrating their vision.
Right. Now, is any particular, what would be we did talk about the causes of cataracts. Is there any new procedures in the future about cataract procedure?
Well, there's some neat
Removal.
drops that are being studied that can affect how the bonds cross-link and how the lens stiffens. And will those drops lessen the need for reading glasses so that people, you know, don't get a stiff lens? And are those drops going to play a role someday in lessening cataract progression? There's research going on like that that's promising.
All right. Well, we're getting some questions. A Mitchell woman asks, what does a big splash of blood behind her eye mean? We see blood in the eye, big red. What does that mean, Mike?
Well, it depends if she's seeing it when she looks in the mirror and sees
Right.
that red splotch, and I think that's what she's asking here. So it means a blood vessel's broken on the surface of our eye. We're very used to seeing that on our skin. It turns blue, it's a bruise,
Yeah.
and we don't think anything of it.
Right.
We see it in our eye and it's very dramatic. It's a bright red color because we don't have the skin overlying it, so we're really seeing the true red color coming through. And it's terrifying.
Scary.
Yeah, people, and they wake up usually in the morning. Most of my patients seem to come in and they say, I didn't notice it, I was eating breakfast and my
Right.
husband looked at me and said, what's wrong?
Yeah.
And they rush right in. And so it looks like the end of your eye as you know it, but 2 to 3 weeks later it fades away just like a bruise would and it gets back to normal.
Right.
We don't always find a cause for that, but sometimes
Maybe aspirin.
aspirin use, or if they're on Coumadin or something, we'll have them check their levels, make sure they're not out of line with where they want to be.
You know, and a lot of my elderly patients just have tons of bruises in their forearms as they get older and older and older. They just have more fragile skin,
Right.
and so it is with their conjunctiva.
Sometimes even with just a sneeze,
Yeah.
or rubbing their eye, or weightlifting. You know, so some of those things can just cause them.
Right. A woman, a Rapid City woman, asks, when you have cataract surgery, I have heard there is an adjustable lens that has adjustable focus. Are those developed enough that they're good and safe, and do you recommend it, or is that questionable?
Well, there's a couple ways we use the phrase adjustable. Like the Dream adjustable is our natural lens, like when we're younger, and it zooms in for near and zooms out for distance.
Right.
And that Dream lens after cataract surgery has not been developed. We dream of that. There's another lens, though, that's adjustable. How we talk about when you calculate the implant power, usually you have to live with that power once it's in your eye.
Right.
Some of the research we're doing right now, it's called a light adjustable lens. And I did one of those adjustments today, where the patient has the implant, and then 3 weeks later, ultraviolet light polymerizes the lens in a way that it changes its power, so you can get them to 20/20, and then when they're happy with that, you lock it in for the rest of their life. So that would be a light adjustable lens.
That's new. You do those too?
I know it's in research
Yes,
right now.
it's
so you're
very,
part of the
very,
study.
early, but it's now actually FDA approved and about ready to be released the second half of this year. Yeah.
What is the protocol on those for? You wear sunglasses, right, to make sure
Right.
it doesn't do anything accidentally?
That's exactly right. This ultraviolet light that is going to very specifically change its power, you can get ultraviolet light from the sun that could affect it. So you wear glasses, and they can be clear UV protecting or sunglasses for that first few weeks to protect it, so you can adjust it very specifically.
Right. So that's new stuff. We do have some information about glaucoma. Now there's interesting macular degeneration. People lose their center vision, but they have peripheral vision. People who have glaucoma lose their peripheral vision, but retain their central vision. Tell me a little bit more about glaucoma.
Yeah. So glaucoma is a disease of the nerves of the eye, and so we often hear about pressure in glaucoma because that's the biggest risk factor that we know of for glaucoma is pressure. So most people who have glaucoma have a high pressure, but not everyone. You described it perfectly, which is it takes away your peripheral vision. And that's part of the reason glaucoma is such a dangerous disease is you don't realize it. You know, no one notices that they're missing something way out to their side here, and they might not notice it until it gets
And it's almost going to, and it'll take that central vision
It'll
in
give
the
you
end.
tunnel vision, and then at the end it'll actually take the center too.
So we can treat that.
Yes, and that's why it's so important to screen for it.
Okay, and we do have a video. One method of treatment of glaucoma includes the placement of a stent, a reminder that the following graphic video might be a little disturbing for some.
We're going to make a small incision. We're going to put a little bit of numbing medicine inside the eye, and that's all you need. Everything looks beautiful. I'm going to put some gel inside the eye. That helps keep the eye nice and stable and nice and formed. Okay. I just make 2 tiny little incisions. That gives me access to everything that I need. This device that we're putting inside your eye is the smallest device ever implanted into humans. It's so small it'll fit in the ridge of a fingerprint. And what it does is it helps the fluid inside the eye drain better. To help lower your eye pressure, to protect you from glaucoma, and hopefully make it so you don't need as many glaucoma eye drops. Here, if you look on the very end here, if you can zoom in, it's just that very tip. It's smaller than an eyelash. It's just that part at the very end that's pointed to the left. Smallest device ever implanted into humans. So we go into what's called the angle of the eye. Look to your left just a little. Yeah, that's great. And there's this kind of circular meshwork that drains the fluid. And so I just go when I find that location and I slide this little stent in there. A little bit of pressure there, good, perfect. Looks great. Good job. And that's it.
I think that issue of glaucoma is one of the major reasons that we really all, at the age of 50 anyway, start at least a yearly checkup by an ophthalmologist or an optometrist and get our pressure checked. Would you disagree? Either?
I think we would even say 40. You know, I mean, this is, since you don't get that vision back, you know, I think before the age of 40, every year or two you should have an exam. But after the age of 40, I would say every year you should have your eye pressure checked because like Mike said, it's painless and people don't know they're losing it and you don't get it back.
Yeah. Now, I mean, we just saw them put one of the tiniest little stents that I've ever seen in an eye, but usually glaucoma is treated how?
Typically with medications, drops most commonly. We've been very fortunate to have a lot of medications come out over the last 20 years to treat glaucoma, and so most people are well controlled with 1 or 2 drops. The stent is a good option for someone who maybe fails those or is going in for cataract surgery anyway and has maybe an allergic reaction to some of the drops or some reason that they'd like to get off 1 or 2 of their drops. Oftentimes they're still using, let's say they started with 3 drops and they get a stent placed, well, they might be using 2 afterward instead of 3, but the goal is to get the best control possible.
Right, save the eye.
And sometimes you can put in more than 1 stent. You can put in 2, and cataract surgery itself lowers eye pressure. And so in combination with the stent, it can be a very effective, and it's just a great time. It's a great opportunity to lower pressure when you're already in there doing cataract surgery.
There is another kind of a blasting kind of a thing that they do. I had that for my glaucoma. where in the office, I'm sitting there. It wasn't comfortable. And Dr. Osmundson did that. Can you explain what that is?
Was it a SLT laser or?
I don't know. It
so
was,
there's some lasers for it too. So drops are kind of first line. For some conditions, though, laser is first line where they use the laser to open up what we call the trabecular meshwork, the drainage system of the eye. And so that kind of, I tell people, opens it up so the fluid can get out of the eye and the pressure can go down.
Right. It wasn't a big deal, but
Wasn't your favorite?
you know, I said, "Ow, that hurt." It's sort of like getting a shot, you know.
But just so you know, a lot of patients don't say ow, and they feel like it wasn't too bad.
Oh, okay. All right, I'm a wuss, no question about it. A Sioux Falls man asks, what is the percentage of cataract surgery or lens transplants that has a poor outcome, and how is it remedied? Vance?
Well, you know, we always say that even though cataract surgery we consider is low risk, one of the most successful surgeries known to medicine, it's not no risk. And you know, one of the big risks we talk about is infection, but it's extremely rare. Or one of the risks is sometimes the retina can swell or detach. Doesn't happen very often, but a lot of these things are treatable. But that's why you wait until your vision is frustrating you, because there are these small but significant risks.
Potential risk, no matter what. Sioux Falls woman with diabetes has an A1C of 8, which is actually a little bit on the high side, but the real New England Journal of Medicine article said 8.2. Now everybody says 7. Hemoglobin A1C of 7 or less is a better deal. It's a 3-month average of a blood sugar. She has a hemoglobin A1C of 8 and can't control it. How soon does that affect eyes, and what does the progress look like? And my comment to her would be, it depends upon how old you are. If you are in your late 70s or into your 80s, 8's pretty good. You can get into trouble trying to control it. But to that question, let's say she's a 50-year-old woman with a hemoglobin A1C of 8. How long do you expect that to give trouble?
Yeah. So the higher the A1C, the more likely you are to have problems. Most people who show diabetic retinopathy happens about 5 years after, well, for type 1, it'd be about 5 to 10 years after diagnosis. For type 2, it's actually less time, because we often diagnose that later. We don't know they had diabetes. Yeah, maybe she's been running at 7.9 for 5 years.
Yeah.
So how soon that causes problems for? Maybe never, but the higher that gets and the longer it runs at an elevated range, the more likely she is to have trouble, especially if she has some family factors involved.
Right. My philosophy as an internist who took care of many diabetics for many years, the tightest control you can get is your goal. Without reactions, without passing out, without having an insulin reaction, or without having low blood sugar problems. Because every time you do that, that's like 10 times more dangerous than the long-term.
It's a do no harm kind of situation.
Absolutely. So be very careful. And so aggressiveness is fine, but as you get older, I get less aggressive.
But also to remember, the eyes are the windows to the soul. And when you look in there at those blood vessels, they're telling you about what's going on in the rest of the body.
Yes.
How's the heart? How's the brain? How's the peripheral vessels, you know, in the feet? And that's why that eye exam is so important every year for diabetics.
It talks about vascular health, doesn't
Yep,
it? Better than
exactly.
almost anything.
It's a beautiful window.
We do have a question. LASIK surgery, 50 years of age, Vance. Would you think that that's a little bit too old for LASIK surgery?
No, nope. It's a matter of expectations. Just like fitting a pair of contact lenses or a pair of glasses, if you see great with your glasses and you want to see great with them off, you're probably a good candidate for LASIK. If you are blurry with your glasses, you may have something else going on, and LASIK is not going to be your answer. So if you're doing great with optical devices, then LASIK can be for you. But what you want to remember at age 50 is that lens behind our eye has starting to get stiff.
Right.
And so you may need reading glasses, or we may need to do monovision or something like that.
Okay. Glasses and contact lenses are common ways to make up for failing eyesight, but for some there is another way to improve your sight. A reminder that the following graphic video might be disturbing to some.
Now I'm going to go ahead and put on another little drop. You just keep relaxing. And now you're going to feel some pressure. This is where I don't want your head to drift up or down. You'll just feel some pressure. It's almost like a big eye hug. Your vision's going to dim out. Are you doing okay?
Yeah.
You're doing really good job of not moving your hands or feet.
Okay.
A little more pressure. And now you just keep relaxing. This is a good time to not talk or move. Just keep relaxing. Keep holding still. Keep holding still. And now I'm going to go ahead and release the pressure. Wow, you're doing great. And up. That went perfect. And this bed's going to rotate to the laser that does the correction, okay?
Yeah.
So you just keep relaxing. Now I'm going to have you look at the blurry green light. The tracking device is locking on, and just beautiful how it follows the eye. Just don't worry about the noise. Just keep concentrating on the green light. Just keep relaxing. Don't worry about the laser fumes or anything. Just keep holding still. Wow, you're doing beautiful. Here's some drops. And I'm going to put this little drape on the eyelashes. Just helps keep them out of the way. And here again is a little eyelid holder. You just keep relaxing. All the data is entered into the laser computer just perfectly. We're double, triple checkers, and it's just perfect. So you just look right at the green light, and don't worry that it's going to move around a little bit. That's normal. Just keep relaxing. Now I'm going to have you look right at that green light. You're doing absolutely perfect. Don't worry about the noise. Just keep looking at the green light. You are doing so perfect. Absolutely perfect. Smoothing the flap into perfect position. Your flaps went beautiful. Your corrections went beautiful.
Okay.
LASIK doesn't go any better than this, buddy. And tomorrow you'll be driving without glasses. Isn't that exciting?
Sounds good.
I mean, I'm just so happy for you. Drops. I'm going to take off the little eyelid holder. You can blink all you want. I'm going to dab the drops a little bit. We'll take these off, and we'll take this off. And you just relax. I'm really, really happy for you. Congratulations.
Thank you.
Don't worry when you sit up. Even though your vision's already better, it's going to be way better, okay?
Okay.
And we'll see you over in the office, okay?
Okay.
Congratulations.
This is your program. Your questions are key to the direction of our discussion. Call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org. We did get a question about keratoconus. Mike, what is keratoconus?
So that cornea we were talking about earlier, the window of the eye, is normally a nice round shape. In some people, it gets a thin area and actually bows and gets a steep cone shape, so keratoconus. We get this cone shape to it, and obviously that kind of diffracts light in weird ways and gives this difficult vision that even glasses sometimes can't fix for people.
So what do you do for it?
Well, we have a few options. In the last couple of years, they've been doing it in Europe for a while, but they've started doing cross-linking here in the United States, and Dr. Thompson's been a part of some of that, but where they actually shine a light on the eye with a vitamin on it to try to harden it and basically freeze the cornea where it's at so it doesn't keep getting more and more pointed over time. So that's one way we can try to stop it today, which is exciting to have something to prevent it.
Right?
That's
really
new.
new.
Yep. For a lot of people, though, who maybe they aren't progressing anymore and they just have vision that they can't fix with glasses, contact lenses are the option. A hard contact lens takes that cone and pushes it back down. You can't put a soft one on it because it just drapes over it and keeps that same shape. So you need a kind of the old-fashioned, almost hard contact lenses, but they have some new versions. People who failed contact lenses 20 years ago, they'll come back in and say, well, that doesn't work for me, I want a transplant, and that's kind of our final option. But I'll send them back for some of these new contact lens options because I've had a lot of good success with those.
Well, when you do a transplant, does it ever come back?
So transplants can have a lot of issues, but no, the keratoconus doesn't really come back. The transplant can fail in some ways. It's like any tissue or organ transplant, the body can reject it. It can swell in a way or it can be misshapen in its own way, but it doesn't really get that thin cone shape that keratoconus is.
And I agree with Mike. And also keratoconus, the eye rubbing that we see of people from allergies that are untreated that have caused their own keratoconus. And we even ask if they face plant into a pillow, looking for something physical that has weakened that cornea to try to prevent that, to slow its progression. There's things the keratoconus patient can do.
Right. Now, and you've said this to me many times on this show, don't rub your eyes.
I ask every patient, do you rub your eyes? Hi, I'm Vance. It's the first thing I ask.
Do you rub your eyes?
Because I've seen too many people ruin their eyes from eye rubbing.
Yeah, and you're total agreement.
Yep, that's 100%
Stop
agreement.
rubbing your eyes. Anytime you kind of,
yeah, people are going to rub their eyes at some point. I usually say use one finger. Corners are better than pressure on the eyeball, because that's really what we're talking about, is pushing on that eye.
Yeah, do not push on that. I've just seen people crank like nobody business.
I tell them skin against bone, and then you're just going to get wrinkles, and I don't care about that. But then they look, because they care about them. But skin against bone isn't going to hurt your eye.
Okay. Now we've got a bunch of questions, so we're going to run through these. One man asked you to comment on the impact of computer phone screen time on kids and their eyes. Mike?
We were actually talking about this earlier. It's a common one in today's age because we're all using devices more and more. It can lead to some more nearsightedness. We're seeing kind of as a general trend, but overall, you know, like sitting close to the TV, mom used to say don't do it. Doesn't really damage the eyes, but it can cause some nearsighted issues and some maybe irritation, dryness, fatigue, those kinds of problems.
All right.
And it can also affect your sleep rhythm. You know, there's been some studies that have showed when kids spend time on their handheld device before sleep that they may have no or way less REM sleep. So you really want to give your eyes a break before going to bed.
All right.
Blue light can do some things.
Wonderful, important idea. So there it is. Now we've got 24 questions. We've got
Rapid fire.
Rapid fire. One viewer asks, I get little spots in my vision where I can't see there are surrounded by flashing lights. The flashing lights then get bigger and drift off. This is sometimes accompanied by headaches and sensitivity to light that last about half an hour. What would you say causing those episodes? Well, it's migraine headaches.
I was going to say, it's like a test question right there. They kind of spelled that one out.
Perfect history. What would you do? See your primary care doctor or a neurologist about it?
What I usually do with this is I do a full exam, make sure it's not something from the retina causing some flashing lights, and maybe they're describing them
Sometimes
incorrectly.
detached retina, for example, can cause it.
The other thing, what's a nice test for patients is it in both eyes simultaneously? Because this is almost always both eyes simultaneously, same spot. And that's how we know it's coming from the brain, not from the eyeball.
Okay.
So if they see it in their right eye, try closing the right eye and see if you have it in their left too.
All right. 65-year-old man from Ottawa, Iowa says, I have lots of floaters and every once in a while I have an aura. Looks like looking through a window pane on a rainy day. What can be done to prevent this, Vance?
Well, I don't think there's anything that is going to be done to prevent it unless you find out what the cause is. But sometimes it's these vitreous floaters, and some of these floaters, the vitreous being the gel that fills our internal eye, sometimes when it separates from the retina, it can have a really big floater, and when it floats in your vision, it can affect things. So number one, you got to get an exam. The same migraine type vascular things can cause some of these auras. And so the same exact things that Dr. Eide said he should do.
A Sioux Falls woman said, I have dry macular degeneration. Is there treatment for that, or does it just gradually get worse? Mike? Dry macular degeneration or wet? Explain the difference.
Sure. So dry macular degeneration implies that there's changes in the retina that are happening because of age usually, that are deteriorating its ability to pick up light. The retina is like the film of the camera. It picks up the light and sends a signal to our brain. So that's dry. Sometimes it converts to wet, which is where a blood vessel will break through and leak blood into the eye. So that's the wet, is actually blood in the eye. For wet macular degeneration, we've fortunately had some treatment changes the last 10 years where we started injecting medicine into the eye, and a lot of people know someone who gets shots in their eye, and they say, that sounds terrible, I could never do that. But it helps, and it's been a godsend for wet macular degeneration. Dry macular degeneration, we don't have as much. We have eye vitamins, which went through the National Institute of Health as a pretty big study. It reduces rate of progression, or excuse me, it reduces the number of people who progress in the studies, but it's not any kind of reversal of problems.
Right. I think the major thing with prevention is don't smoke, exercise regularly, eat less, have a friend that you talk with, and have a spiritual center. I mean, that's as good as any.
Everything else you do for your general health is what you should do for dry macular degeneration.
One viewer says, I have Fuchs dystrophy and macular degeneration. What is the prognosis? Is there anything I can do to prevent a negative outcome? Vance.
Well, with Fuchs, that is a dystrophy of the cornea. The cells on the back of our cornea look like little honeycomb, and they suck water out of our cornea into our eye, and we're born with one set. And over the years, we can lose enough of them that it starts to swell. And that layer can be replaced, and Dr. Eide does that surgery where he can replace that layer. And if it's in combination with macular degeneration, you are trying to do an exam and trying to help the patient assess how much is the retina, how much is the cornea, and you just try to do the best job with each. But once you help that cornea, oftentimes you've helped that patient a lot.
Now, it's a tough one. You do those transplants, don't you? The internal, you push the lens in.
Yep, I tell people it's like a contact lens goes on the outside of your eye. These transplants go inside the cornea and go onto the back side of it. So it's very similar to that.
Wow, and you don't really always know how much is macular degeneration, how much is Fuchs dystrophy. It would be hard.
This is something where your doctor would have to give you even a guess as to how bad the macular degeneration is, because sometimes it's all of the problem and the Fuchs is none of it, or vice versa.
But we see the same question with cataracts and macular degeneration. But oftentimes the cataract surgery can still help them, but just not as much sometimes as they hoped.
Quickly, Medicare covers cataracts?
Yes.
Very well.
LASIK lasts how long?
Well, it lasts for the rest of a person's life because the correction's permanent, but their internal eye can still change, and that's why we don't do 10-year-olds. But once they get into their 20s and 30s, when they say their prescription is slowed down, then they get to enjoy that correction for many, many years. But sometimes someone 20 years down the road can use a little additional fine-tune.
One viewer asks, please discuss map-dot fingerprint dystrophy. Map-dot fingerprint dystrophy.
Yep.
Mike?
Map-dot fingerprint. So what that is the cornea, that clear cover again, in the surface layer. So Fuchs is on the inside layer.
Right.
This is the epithelium, the outside layer of that cornea. Gets some ripples in it, is usually how I describe it to patients. It's not as smooth as it should be. The nice thing about that is it's fairly treatable either with lubrication and trying to smooth it out that way, or sometimes we'll just take that epithelial layer off, and I do that right in clinic and let it grow back in. I know Dr. Thompson will do something similar with the laser.
Right, sometimes you can laser smooth it too. But the majority of our vision, image quality, happens right where the air meets the tear film. That smoothness is so important, and map-dot fingerprint, with its undulations and ripples, it affects the tear film, and light rays ricochet and it's blurry. But the beauty of it is very treatable.
Treatable. Hot Springs woman says, I had cataract surgery quite a few years ago. The retina on my left eye was burned. Can you explain why and how you think this happened? Mike?
So it's cataract surgery? Is that
Cataract surgery quite a few years ago.
So
retina was burned.
Oh, the retina was burned. Could have been from exposure to the light with long surgery. So you saw in Dr. Thompson's video, we have to have a microscope light shining into that eye. And we all know from staring at bright lights, it doesn't feel good, and we're not supposed to look at the sun because you can actually cause solar retinopathy or burns of the retina. Back in the days of 1, 2, 3 hour cataract surgeries, you could get too much light. So they had a lot of light exposure. It doesn't really happen anymore with cataract surgery. Maybe with some other surgeries it could, but.
Okay. California woman asks, what are the pros and cons of Vyzulta drops for glaucoma, Mike? Or Vance?
I wish I knew the answer to that.
Do you know
Yes.
Vyzulta?
Yeah.
Vyzulta, I don't know that drug.
Glaucoma? I haven't heard of that drug either.
Yeah,
And
But I think it is worth talking with your glaucoma doctor. You can get a lot of good information online, but it's good to talk with your doctor and see how it interacts with other medications and side effects. But I don't know specifically with that one.
Vyzulta.
No, the newest is Repressa. That's the newest one I'm aware of, so I don't know Vyzulta.
So if I'm having trouble with tears and I need an artificial lubrication, I've told people over-the-counter artificial tears and an ointment at bedtime, but I don't know which one to recommend. Do you guys give, real quick, like any recommendation?
Well, I don't necessarily, there's a lot of great ones out there. One of the things I'm sensitive about is preservatives, because dry eye patients oftentimes need a lot of lubricants, and I'm a big fan of preservative-free, whether it's drops or ointments.
Are they available OTC?
Oh yeah, they're available.
So
OTC.
preservative-free.
Usually, when
Same
they're
brand.
they're in the little twist tubes.
So the individual twist
those
tubes.
those are preservative-free.
Oh, there's a better deal.
Yeah, and then, but it takes, you want to have a good eye exam too, because there's also medicated eye drops that treat the surface inflammation and actually help you to naturally produce more tears.
Okay.
And so if you're putting on a lot of lubricants, you really just want to have a good eye exam and develop a good dry eye plan.
Right, okay.
And I typically tell people I agree with the preservative-free, but I also say avoid anything that says it gets the red out.
Yeah, don't do that
Don't
one.
do that. You know, the Visine red eye or the clear eyes or those.
Right.
They're
Yeah,
bad.
look for a lubricant drop only. Don't get any of the extra.
Okay.
Right.
Did a set of cataract surgery, both eyes, without the pre-drops, had to come back 7 months later, and they did something other than surgery, and they said that that was all they could offer. I'm going to go blind from these surgeries. Vision is getting worse and eyes burn still. Doesn't sound like a happy camper.
You know, when I see someone like this, first of all, I feel sorry for them about how they feel. But there's never been a study that has shown that pre-drops are absolutely necessary. So some doctors use pre-drops, which means drops 1 to 3 days before surgery, but there's doctors that don't. There's no drop FDA approved to use pre-cataract surgery. So when you're using it, it's oftentimes because we just have a gut feeling we want to make that tear film a little bit more sterile. But I don't think she needs to think, if that doctor didn't use pre-drops, that affected her vision
And
forever.
some people
Yeah.
are losing their vision no matter what you do. You do the surgery to try to save things,
Yep.
and then she feels like it might have been the
But
surgery.
a good second opinion could help her too,
Yeah.
to bring some inner peace.
Anything more, that's
I
an
agree with the
important
second opinion on that, because it sounds like she's lost some confidence in her doctor,
Yeah.
and that happens to all of us, I think, at some time.
So my patients never lost confidence in me. I practiced too long to say that, honestly. A Fulton woman says, I will be 60 in 5 months. I've been told by my optometrist that I'm legally blind without glasses, nearsighted, and I'm interested in LASIK surgery. Could I be a candidate for a procedure?
Well, first of all, don't be intimidated by the legally blind aspect, because it only takes 2 units of nearsightedness, a very low level of nearsightedness, to be what would be legally blind. But if your glasses make you see crisp, then you could be a candidate for LASIK. But once someone's getting into their 60s, we're starting to look at that lens to see, is there any cataract? And sometimes it's hard to just look. So before I do cataract surgery on someone who's 60, LASIK surgery on someone who's 60, I like to measure optical scatter happening in that lens.
Yeah.
So I can tell them how well that lens is functioning and whether or not they should have LASIK or just wait for lens replacement.
Okay. A Mitchell woman said BBC News broadcasted an injection for macular degeneration can do it on younger people to prevent during old age. Are you familiar with it, and would it bring it? Can we bring it to the U.S.?
Not familiar with the preventative injection. Most of the injections they're dealing with are more stem cells and things reversing. I doubt that comes to the U.S. anytime soon.
Yeah, and I would doubt that it really does work. BBC News. That's
Well, the thing is, you'd have to wait. If they're doing it on young people, what do you wait 40 years to see if it worked? You know, like that's going to be a difficult study.
Yeah, that's going to be a hard study. One viewer asked, I had cataract surgery 2 years ago. Ever since, I've had fluid-filled blisters consistently on the whites of my eyes. They are not painful and they don't obstruct my vision. Should I be concerned or should I see my doctor? That's a good one, Vance. Blisters on the whites.
Well, in the conjunctiva, the surface of the eye, you can get these little cysts, but they're harmless and they don't mean anything, and they typically, you don't even feel them.
They're not related to the cataract surgery?
No.
Yeah, they may. Sometimes I've seen different surgeries where you cut through the conjunctiva, you get some trapped cells there, and you
Right.
do form a cyst. But as Dr. Thompson said, they're harmless. I recommend leaving them alone in almost every case.
Right.
We have a question about a pterygium, and we do have a picture of a pterygium. I don't want to spend time on it, but a pterygium is a growth that's coming in toward your iris. Do you ever take this as pterygiums out?
I do, yeah. So pterygium is sun damage and dryness, irritation. So we see it a lot in people from southern climates. And what happens is some of the white part of the eye basically grows onto the out onto the colored part, or on the cornea actually, but it looks like it's on the colored part.
And you can surgically remove
And we
that.
surgically remove those, yep, if they're large enough. If they're small, we leave them be. This one is kind of an irregular looking one, and I know that just from looking at a lot of them, so I do recommend everybody have their eyes checked. And sometimes we can find some squamous cell cancer hiding inside of them. So
that's a good idea to get rid of. One woman asked, do you recommend Xiidra for dry eyes? Are there groups that help with the cost? Is there surgery to alleviate dry eyes? Vance?
Well, I absolutely love Xiidra, and I think it's exactly one of those medications that treats the surface of the eye in a way that you can actually start to produce more of your own tears.
It's expensive though.
It is expensive, but there's a ton of help. There's a great website for it, and our offices will help them figure out how to afford it. And there's other treatments too. There's not really a surgery for dry eyes, but we do block the drainage channels. We call them the punctum with plugs, because I tell people there's no tear better than your own tear. And so if you can plug the drain so they don't leave so quick, the plugs can be so helpful, but so can Xiidra.
Yeah. A Rapid City man says, I have good health. I wear glasses primarily for reading. The lines of sight of my left and right eye are divergent about 2 to 4 degrees. My optometrist did not have a fix for the divergent. Early in the day, I do not have a problem, but late, I'm tired of the, or with 2 beers, I find myself reading with one eye because there's a divergent of my eyes. I'd like to read. How serious is this, and is there anything to do?
yeah, so the eyes are basically 2 cameras, and most of the time, those 2 cameras are pointed at the exact same spot. So we get one image to our brain. If one of the cameras gets off kilter a little bit, all of a sudden we're getting a picture from over here and a picture from over here, and our brain can't merge them, so we get what he's describing, kind of double vision. It can be caused by a lot of things. It sounds like you see an optometrist, but we want to make sure that we've kind of ruled out things like tumors, aneurysms, all the bad things, right?
But they can fix it now with lenses?
So lenses can have prism put in them to align things back up. So it's almost like a periscope. One eye gets brought up and one eye gets brought down, so they're on the same page.
Okay. And now for the winner of tonight's Prairie Doc quiz question. If left untreated, the most common cause of blindness in the elderly around the world is caused by glaucoma, macular degeneration, or cataracts. Gentlemen, cataracts.
Cataracts.
It was Idris Quaymar who answered the question correctly. Thank you, Idris, for participating, and a book will be in the mail to you soon. We'll be right back after this. Washington Irving once said, "There is a sacredness in tears. They're not the mark of weakness, but of power. They speak more eloquently than 10,000 tongues. They are the messengers of overwhelming grief, of deep contrition, and of unspeakable love." Normal human tears are a biological wonder, composed of a watery portion for providing the cornea hydration and nutrition, a mucus lubrication component for making a tear slimy, and a third thin outer layer of oil for slowing evaporation. Put together, you have the astonishing, life-sustaining, curative, slippery, and slow to evaporate human tear. Vision is completely dependent on tears because the cornea, for purposes of transparency, is designed without blood vessels and is kept alive only by the nutrition it receives from tears. Dry eye is from many causes involving the eye's surface. It's further described as symptoms from the loss of the effectiveness of tear film. These symptoms include pain, itching, burning, redness, and mucus around the eye with fluctuating vision that interferes with recreation, reading, and even driving. Paradoxically, watery eyes usually indicate a dry and inflamed eye with reactive and poor quality tears. The most common causes for dry eye are side effects from many medications. These include decongestants, antihistamines, and meds for acne, fluid excess, blood pressure, and bladder spasm. Environmental causes include extensive reading, eye surgery, excessive computer use, contact lenses, low humidity, wind and fans in the face, and the result of a diet without enough oil or certain minerals and vitamins. Primary medical causes for dry eyes include immunological conditions like diabetes, rheumatoid arthritis, lupus, scleroderma, low thyroid, Sjogren's syndrome, vitamin A deficiency, and just plain aging. Dry eye affects twice as many women as men, and in the U.S. alone, we spend $3.8 billion in healthcare dollars for this condition, with societal costs estimating at $55 billion a year. For treatment, we could focus on which situations cause symptoms and then find ways to avoid those situations. We can include in our diet enough fish, flaxseed or flaxseed oil, liver, carrots, broccoli, and walnuts. Protective eyewear can help. Doctors treat some cases with surgery by plugging the tear ducts that drain tears away. Eye drops that reduce inflammation can help. Artificial tears are often prescribed, but as helpful as tears from a dropper may be, they're never as good as the real deal. Nothing will ever compare to the value and the sacredness of a human tear. Five seconds each on the sacredness of the human tear. Any comments?
You said it best when you said there's not any drop better in a bottle than what we have naturally.
Right. Vance?
It provides us nourishment, lubrication, and vision. It is beautifully complex.
Thank you. Well, a big thank you to our guests, Michael and Vance, for braving the winter weather and volunteering to come to our studio in Yeager Hall on the campus of South Dakota State University. We are all lucky to have this level of eye care available in our region. There were many great questions we were not able to get to during our broadcast time. Thank you. We will continue to answer those questions on our Facebook page following the program tonight. Go to the Prairie Doc Facebook page. We'll be there shortly, right after this broadcast ends. This additional segment will also be posted on our website, prairiedoc.org, in the coming days. The flu season is really taking off lately, and it's not at its worst. Compared to last year, we're way ahead. 13 people have died in South Dakota this season. Almost 1,000 new cases last week brings the total so far to over 4,600 cases. It really isn't too late to get your flu shot. It's important not just for you, but for those who are around you. Well, that does it for tonight from all of us here at On Call.
It is time to focus on women's health issues. They make up the largest part of the population, but are often forgotten. Maternal and feminine health issues. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
American Academy of Family Physicians Foundation, and South Dakota Academy of Family Physicians.
Avera Heart Hospital,
Dakota Allergy and Asthma,
CoBank,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
Black Hills Medical Society,
Aberdeen District Medical Society,
3rd District Medical Society,
the 7th District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy.
and Swiftel Communications.